Hi, everybody. So this week we're going to carry on with our X-ray series. Uh, and our X-ray series had started from facial injuries and went all the way down, and we had stopped for a little while. So we're going to talk about pelvic injuries. And I'm actually going to divide this into two parts for two reasons. Number one, I've noticed that on some of the longer videos, some of the people have said that it's a bit difficult for them to watch it all in one go. So I'm going to cut it down to more bite-sized pieces so that people can watch it. And number two, there's some important concepts to understand before we look at the X-rays themselves. Okay. So if you hear another voice in the back, that's my little baby. He's also here, and he's giving me company as I'm recording this. So you may hear him in the back. He's also learning about pelvic injuries. All right. So let's have a look and see. So the question that we need to ask ourselves is, why are pelvic injuries worrying? So there's a few reasons. Number one, the pelvis is a very vascular area. So we're going to explore all of these concepts, but it's a highly vascular area with a lot of major arteries and veins that run through it, and damage to these can cause large amounts of blood loss. So that's the first thing. The second thing is it's a ring structure. So any ring structure, which we'll also discuss just now, it has a potential to hold large volumes for blood loss. So without much change in circumference, you can often find the volume that's the volume of blood that's then contained in the pelvis can increase exponentially. And you've got so many important organs that are contained inside that pelvis, the reproductive organs, the what you call the bowel, the rectum, so on and so forth, So it's a strong structure, but it is relatively exposed and it's vulnerable during blunt trauma, which we'll also discuss in a little while. And it often requires extensive surgery. For those of you who have had the opportunity to maybe rotate through orthopedics for a reasonable amount of time, have done your internship, sorry about that little pause. My headphones were being ripped off my head, and the little man over here. So, and the last thing, like I was saying, was it often requires extensive surgery, and it has a very long recovery period. And very often, the injuries can lead to lifelong disabilities, or very severe consequences for the patient as well. So we're not. The thing is with pelvic injuries, it's an extremely complex topic. There's so much that you can learn, and there's so much that you can read in terms of different classifications and different potential injuries and potential outcomes, potential solutions, things like that. So the important thing that I try to work through was basically these. All right. So let's start looking at them a little bit. So let's have a look at the pelvis. So for those of you who don't know the anatomy or maybe just forgotten about it, here you go. You can have a few seconds, maybe just pause the video and just have a look at them. All right. So of course, you're looking at your superior and inferior rami, which are maybe not mentioned on this particular one. Your coccyx, your sacrum, your lumbosacral, your iliosacral joint, which is also extremely important, your iliac crest, your anterior superior, anterior posterior, so on and so forth. Right? But the most important thing is that it actually forms a ring, not in the traditional sense of a wedding ring, but in that it's a round structure. Okay, and you include the sacrum in that because very often pelvic injuries include the sacrum and the coccyx and things like that. Now, the thing is, it has multiple structural weaknesses. So, for example, the inferior rami are considered a structural weakness, as is the acetabulum, as are the iliac crest. But these are important in terms of movement. So you could have had you could have had an absolutely solid structure that was running around here, and it would have worked, except that your movement would have been extremely difficult. So it doesn't, whatever your affiliation may be, whether you believe in evolution or design, I'm not worried about that. But whatever it is a very potent structure because it allows so many things to occur in a relatively strong structure that whose weak points are there for a reason as well. All right. So for those of you who haven't maybe figured out where most of the weak points are, let's just have a look at that again. So these are the weak points, right? So your inferior rami, your superior rami, your pubic symphysis, your acetabulum, your iliosacral joint over there is also quite a weak point as well. So the rest of it is quite strong. So the iliac crest themselves, the iliac bodies are quite strong in themselves. And generally, this little area over here is quite strong as well, beyond the acetabulum. And then, the rest of them are quite weak, So it's a beautifully, like I say, evolved or designed structure, and it serves its purpose completely. Let's look at the next one. So what are the structures that we are so worried about? So in a male patient, this is basically the pelvis. So if you're looking at the sacrum starting from there, you imagine the pelvis running around. And here you can see some of the bones that are there as well. So we're looking at the rectum, the prostate, the sexual organs basically, as well as the reproductive organs, the urethra. Sorry for that little pause again. The little one was just attacking me. But the main ones that we worry about are the bladder, the urethra. And then, so like I was saying, sorry about rectum, bladder, urethra especially. So these are, and of course the small bowel and large bowel as well. So these are the things that we really worry about in the male patient. The female patient, it's not much of a difference. We still worry about the urethra, the bladder, but then we add on to that the uterus, the vagina, as well as the rectum, the ovaries, the fallopian tubes, and things like that. So while different, they do the injuries to the pelvis essentially affect the same organs in both. Okay.
Go. Yeah.
Right. Let's have a look at the next one. So these are the vascular structures that are present within the pelvis. So as we can see, we have the descending aorta that's coming down over there, the abdominal aorta. Abdominal aorta that's coming down, and then that's coming out into your iliacs, right? And then you've got your large veins as well that are also running through and eventually form your inferior vena cava. So what happens is you have this large amount of blood vessels that are sitting in this ring structure. And once this ring structure breaks and starts to increase in its circumference, it tends to tear these vessels as well. And as these vessels bleed, now remember, even though there's a hole here at the bottom, from a bony point of view, this is actually closed off with muscles, your pelvic floor muscles and that. So this actually now becomes an area for blood to collect. And to understand why it's such a danger, you have to understand the correlation between circumference and volume. So I put this here just to illustrate it quite easily. So, for example, if you have a 7.5 liter bucket, you don't need to actually increase your circumference by 2. So in other words, it doesn't have to become twice as big as what it was before in order to double in terms of the volume that it's capable of holding. And the same thing with the 15. A 15 doesn't have to double in size to become a 30. So your circumference in it, your circumference basically, in a small increase in circumference can lead to a large increase in volume. So this is where the problem comes about in terms of the pelvis. So even if you get a split here, a split here, a split there, and you start getting the pelvic bones moving away from one another, you start to get a large area for blood to collect. And you normally see this clinically on your patients as well. Okay. Okay. So how do I examine the pelvis? So the first thing that you've got to feel for is you've got to feel for what they call bogginess of the symphysis pubis. Now, what happens is that if you have a fracture where the symphysis pubis is affected and you start getting what we call an open book fracture, so that means none of the bones have broken, but the cartilage here has actually caused the bones to separate, then you start getting what they call a bogginess. So bogginess is a firmness. If you can think of a hard jelly, so if you were to touch your symphysis pubis now, you'd find that it's actually quite rigid and quite hard. But if you can imagine it feeling like a bowl of hard jelly, then that's what we refer to as bogginess. Right? So that's the first exterior, what you call it, examination that we do. Any sort of bleeding from the urethral meatus. Now, it's obviously much more easily illustrated on the male, but even on a female patient, if you see something like that, then we assume that there is urethral injury as well. Now, what will often happen is that my personal feeling is that unless it's absolutely necessary, don't insert a urethral catheter here until you've done a PR exam as well. If your prostate is high riding, in other words, you can't feel it within a little short distance in a male patient, of course, then there's a good chance that that urethra is actually damaged. And what's going to happen is that when you insert that catheter, it's going to basically just cause further damage and not go into the bladder. Now, if it's a normal prostate sitting in a normal place, but you have a bit of bleeding, you can still go ahead and take a chance. And I know some of the urologists also say that you can take a chance and just put it in. And if you're not getting any urine, then you remove it and things like that. But what I would say is that if you're not sure, don't go ahead and just do it for the sake of doing it. Rather, ask somebody senior to have a look and see. And then what the other thing that you get is you get a quite severe hematoma formation around the pelvis and the rectum and things like that. And these are all indications of a severe, what you call it, pelvic injury as well. Now, this can extend into the buttocks as well. So that's how you can tell that you've got a pelvic fracture as well. Now, remember, the PR also forms an important part. So you can sometimes find pelvic fragments, and this can be quite dangerous. So I would suggest if you really suspect, double glove. And if by any reason you do get clicked, you've got to treat yourself quite aggressively for that. And, those are quite complicated injuries as well. So, these are the types of things that we look for. So you're examining the symphysis pubis, you're examining for bogginess, we're looking at the urethral meatus, and you're going to do a PR, and you're going to look for bruising around that area as well. Okay. All right.
Yes, no.
So you've seen evidence clinically of what the patient may have. Now, what do you see as well? You may see a patient with low BPs because of blood loss, tachycardia, bruising, etc. Okay, so what's happening is that now you have this patient in hypovolemic shock simply because of loss of blood. All right, so this needs to be treated as an urgent resusc. You can't take this easy. You can't sit back and wait for things to get better. You really need to start sorting this out. So the first thing you need to do is stabilize the pelvis. Okay, now there are specially designed products, which we'll see just now, but even a simple sheet will actually be able to do this. Basically, you've got to wrap the sheet around the pelvis. So what we need to do is, this is the first thing. And the reason for doing the stabilization of the pelvis is that you have to reduce the circumference. And once you reduce the circumference, then basically your pelvis and your pelvic bleeding can tamponade itself. Okay, so this is going to be the last slide for today. And the next time when we're doing x-rays, we're actually going to go through different types of fractures and talk about forces and things like that. But I don't want to overdo it. So this is just a little video to show you how to locate landmarks with pelvic binders. And the video has no sound, but I'm going to talk over it so that you can understand what's going on. So this is one of the most difficult things for people to understand, right? So your patient should be taken down to skin level. Now, of course, they've got the model, so that's why they haven't done it. Now, what I've noticed a lot of people do is that they apply it over the anterior superior iliac spines. So in other words, your pelvic binder is going across here. I'm just going to pause this for a second, all right? So imagine that and let's just annotate this a little bit. So I just want to draw this out. Okay. Let me just get a nice color here. All right. So at the moment, let's look at what our pelvis looks like, right? So that's where our pelvis is. Okay. So this is more or less the axis that it's sitting on. Now, I want you to imagine that you go and insert a pelvic binder across here. All right. So in other words, you put it across there, which is what I've seen a lot of people do. What do you think is going to happen to that axis? So you must remember this is fractured, wherever the fractures may be. But once you apply the binder over those areas, what's going to happen is that as you pull it tighter, you're actually going to make the axis go like that. Should have started it from there, but anyway, let's just do that. So we're going to take it from there. So what's happening is that you're actually increasing the volume once you put it up there. Okay. So this is one of the most dangerous things that you can do. Okay. Now let's look at the converse. All right. Let's start again. So let's say sorry, I just want to get a nice color again. So let's imagine again that we've got our axis sitting like that. So when I say axis, what I mean is this is how pelvis normally sits. All right. And we're going to now apply our binder a bit too low. You're now going to put it around there. All right. So we're putting it a bit too low. What's going to happen is that now, when you are doing it from here, you're actually going to pull those areas closer and actually split that wider. So your circumference becomes a lot wider and you've got a much greater area for bleeding as well. So it is extremely important that you get it in the right place. Now, that's what they're going to show you here. So let's just watch that. Now, they're using a proper pelvic binder, but even a sheet would be good enough. So let's just have a look and see. So what you're aiming for is you are aiming for the greater trochanter. Okay. Now, as you can see, that's where we're going to do it. Now, let's just stop there again and just talk about that. Right? So, just right. So again, we've got our right. Just try and get this properly. Okay, yeah, that's the one that I was looking for. All right. So what's going to happen is now when you apply your binder in the right area, which is over the greater trochanter, you can see what's going to happen is that the axis is going to be pulled closer. All right. So what you've actually done now is that you decrease the volume. All right. So as compared to the other two, it's too high or too low, you now decrease the area for your patient to be able to bleed. Okay, let's have a look at that. So you can see that they're feeding for the greater trochanter. And once you get the greater trochanter, that should basically be the midpoint for your binder. Now, this is a special pelvic binder. So as you can see, it applies tension in two directions. So that's what brings the pelvis in closer to, as I say, moves the axis of the pelvis closer to one another, and thereby decreases the volume. All right. Now, it's extremely important to get this right. Okay. So what happens is you've got a nice thin man here. You can see he's got abs and he's relatively quite small. Now, what happens if you get somebody who's bulging like that and you can't actually, get the greater trochanter, so you can't feel them correctly? It is very difficult, that's for sure. So what you can do is, in order to use any other anatomical marking, I'm just going to illustrate it here. Let's do it in blue and pink. Just better. All right. So what we would normally see is that we would see the scrotum just about here. Sorry, let me just get the scrotum there. All right. And we would see the, what you call it, the base, the penile shaft about there. So you're going just above the base of the penile shaft, more or less. Let's say, but even over the bottom third of the penile shaft. So that's where you'll be basically aiming for in a male patient. Okay. And if you're looking at a female patient, let's just do this in pink. This would actually be the junction of the labia majora. That would be there. So again, you're looking at the tip of the labia majora to the top 20 to 30% around there, and you'll be more or less in the correct area. Okay. So that's how we know more or less where we are. So if you can feel for the greater trochanters, use those anatomical landmarks. Like I say, base of the shaft, top 20% of the uh, labia majora, and you'll be more or less in the right place. There are anatomical variations amongst patients, so it's impossible to say for sure, but at least you know you'll be in the right area. Okay, so we're going to stop there for now. And hopefully next week, or at least the next time we're doing the X-ray, the radiology segment, then I'm going to go through some more X-rays, and we'll actually learn more on the X-ray side of it and the radiology side of it. But I felt it was important just to go through these basic understandings and principles of pelvic injuries, just so that it makes a lot more sense as to what you can do clinically. Okay, I hope you enjoyed it, and next week hopefully we'll have another one. Okay, bye.